Let's begin with the first talk of this session. Takayasu's arteritis, a rare but serious large vessel vasculitis, presents unique diagnostic and therapeutic challenges, particularly in the pediatric population. Early detection is often difficult due to non-specific symptoms, yet timely intervention is critical to prevent irreversible vascular damage and life-threatening complications. A multidisciplinary approach, especially incorporating cardiology expertise, is essential for comprehensive management and improved prognosis. We're privileged to introduce Professor Dr. Masood Sadiq, a highly esteemed pediatric cardiologist and academic leader. Holding FRCP Edinburgh, FRCPCH UK, and multiple distinguished qualifications, he currently serves as Vice Chancellor of the University of Child Health Sciences and Head of Pediatric Cardiology at the Children's Hospital, Lahore. His vast experience and leadership in pediatric cardiovascular care bring a unique and invaluable perspective to this topic. I will request Professor Dr. Masood Sadiq to please come on the stage to share his extensive knowledge with us.
First of all, let me thank the organizers for this kind opportunity. My first disclosure is that I'm not a rheumatologist. I'm a pediatric cardiologist, so my perspective will be obviously different from rheumatology context, but I will try and be to the point. Takayasu arteritis, I have no disclosures to make, no relationship with any industry whatsoever. Takayasu arteritis was first reported in 1830, and this is the most common large vessel vasculitis which we see in pediatric age group. Let me tell you, because I'm a congenital heart expert, so I see adults with congenital heart disease as well. So the perspective will be obviously including both pediatrics and grown-up children, I would say. We all know that it's a chronic granulomatous inflammation, and it primarily involves major branches and pulmonary arteries. And it results in a segmental stenosis, occlusion, dilatation, and aneurysms. Interestingly, Takayasu was not a cardiologist or a rheumatologist. He was an ophthalmologist who actually first reported and published the characteristic findings which we see in Takayasu arteritis. And his context was ischemic neuropathy of optic nerve with annular arteriovenous neoanastomosis. So why does Takayasu arteritis matter to pediatric cardiologist or a cardiologist who looks after children? Very high mortality in pediatric age group. If you compare it with adult Takayasu, this is the only condition other than Kawasaki disease where we see coronary artery disease. We hardly see coronary artery disease in pediatric age group, but this is one condition where we do see coronary artery disease. And of course, these patients, because they have cardiac involvement at the time of diagnosis, hence it's not a rheumatology disease only. I think what presents in pediatric age group is hypertension, coronary artery disease, aortic regurgitation, and of course, most importantly, heart failure. So it's one of the things which is more common in terms of presentation in pediatric age group to a cardiologist than a rheumatologist, although we manage these patients jointly. And I think one of the important things about Takayasu arteritis is the delayed diagnosis. By the time it comes to medical attention, the child may already be in remission, or what we call a quiescent phase of Takayasu arteritis. And of course, Pakistan has a very high incidence of tuberculosis, and there is a correlation, although it's not a proven correlation, between Takayasu and tuberculosis. Let me start with a case scenario. This is a 14-year-old girl, thin, lean girl, presented with shortness of breath and chest pain for 3 months. There was history of palpitation, exercise intolerance, and headaches. 6 months ago, she developed fever, lethargy, and weight loss. Although there was no history of contact with tuberculosis, she was put on ATT. Pediatricians do that all the time. If we get a history like that, most of these children, particularly if they are undernourished, will be put on ATT. But when we examined that patient, she had cold left upper limb with reduced radial and brachial pulse volume. And of course, there was discrepancy and femoral pulses were feeble. As a cardiologist, if I see femoral pulses either being absent or feeble, the diagnosis is coarctation of aorta, full stop. So the only other condition other than coarctation which we will consider will be, of course, Takayasu arteritis. And you can see the limb difference in terms of blood pressure. Of course, her CRP was slightly raised, ESR was 40, and Mantoux was negative. This was the echo, which shows classical left ventricular hypertrophy, which you can see in both four-chamber and log axis view as well as on M mode. We went ahead and did a CT angio. And you can see she had a long segment, what we call coarctation of aorta. Head and neck vessels were also involved, and that's how you will differentiate from a congenital coarctation and Takayasu arteritis. Because congenital coarctation, even if ever involves head and neck vessels, it's only their origin and not distally. If distal vessels are involved, it's almost always Takayasu arteritis. We went ahead and did an angiogram. You can see on the left of your presentation here, over here, a long segment coarctation of aorta. You can see we put in a balloon to begin with to see how it inflates, and you can see a stent has been put in at the site. The moment we put in a stent, you could see that the bottom part of that vessel was also narrow and stenosed. So we went ahead and put in a second stent, and you can see the last angiogram showing very nice profile with no pressure gradient across that long segment coarctation, which on original CT looked like a very simple lesion, ended up with 2 stents. Of course, we started this patient on steroids. After stenting, was discharged home. My rheumatology colleagues at my institution obviously were looking after this patient when it comes to medical treatment. They started her on methotrexate as an adjunct therapy, along with folinic acid, vitamin D, calcium, both were deficient. And she has been on antihypertensive treatment since then and is being followed up. So you can see how pediatric patients with Takayasu arteritis would present, and if present early, could effectively be treated actually. And that treatment, of course, would involve intervention. If you look at the etiology, it's not a very common disease, like 2.6 per million per year worldwide, and 90% of these patients are diagnosed before 30 years of age. Of course, there is some female or significant female predominance, which is more so in adult population than in pediatric population, and the mean age is 12. So we as pediatricians are more likely to see Takayasu arteritis rather than an adult cardiologist or an adult rheumatologist. And I think in a country like Pakistan, where tuberculosis is so common, this co-prevalence adds to diagnostic complexity as well. And it is the vascular complications which really lead to morbidity and mortality. How do we diagnose, or what are the criteria which are being used for diagnosis? I think the mandatory thing is angiographic abnormality of aorta and its major branches. Unless we see that, you cannot make a diagnosis of Takayasu arteritis. And this day and age, I think most of us would go for either CT angio or MR. And I think once we have that, then of course, plus either one of these 4, 5 criteria: decreased peripheral pulses, blood pressure difference between the 2 arms or forelimbs, bruit over aorta or its major branches, hypertension as per normal pediatric criteria, and of course, raised acute phase reactants. Although in adult population, your criteria would be slightly different, like age at onset, weight loss, limb claudication, vascular bruit, again, absent pulses, vertebral or carotid artery abnormalities, abdominal aorta, and conventional angiographic abnormalities. This is the classical classification that we use in clinical practice in terms of involvement of various parts of the arch. If it's only the head and neck vessels, it's type 1. Of course, it involves ascending aorta, type 2A. If it involves also the thoracic aorta, we call it type 2B. And type 3 is where it is also involving the renal arteries. And of course, type 5 combines all the features, or if the whole of the arch, including head and neck vessels, as well as renal arteries are involved. And we add C or P if coronaries are involved or pulmonary arteries are involved. They're not invariably involved. They may be involved, but not in every case, and you would obviously classify it according to that. And if we look at the relative prevalence, the most common area which is involved, you can see, is thoracic aorta, 9 to 69%. And similarly, superior mesenteric artery and renal arteries. So the etiology of hypertension will not only be the involvement of aorta, but also involvement of renal arteries. And that's why the management becomes much more complex and difficult. So how do we differentiate a pediatric Takayasu arteritis from an adult Takayasu arteritis? I think age range, you can see our age group is usually 12 to 17. On the contrary, in adults, it's usually up to 40 years of age. In adults, females are far more involved than when it comes to pediatric population. We see them as hypertension. That's why they end up with pediatrician, with a pediatric cardiologist rather than rheumatologist. But hypertension in adults is relatively less common. Cardiac involvement is almost always there. Renal artery involvement is almost always there. Aortic type, of course, more common to have the entire arch involved. So type 5 and 6, where you also see coronaries and pulmonary arteries being involved. More common constitutional symptoms. The diagnostic delay in pediatric age group is usually 1 to 2 years. But in adults, and I will show you a case, can be decades actually. By the time they come to you, you might have missed the diagnosis for 10 years or maybe even longer. And of course, mortality is significantly higher because of cardiac involvement. So what are the red flags? Hypertension. Any child or adult with hypertension, please look for Takayasu as a possibility. Of course, we are not used to. We have the largest series of coarctation which we have reported in the literature. And you believe me or not, majority of these patients were adults who had been seen for years and years, but nobody checked the femoral pulses. So if you do not feel femoral pulses, you will not pick it up. So I think that discrepancy between upper limbs and lower limbs and presence or absence is crucial. Of course, aortic regurgitation, coronary artery disease, and most importantly, once they get into heart failure. 50% of pediatric population would also have cardiomyopathy. Because by the time you see them, they have developed hypertensive cardiomyopathy. So they will develop dilatation and dysfunction along with severe hypertension. So how do we approach them? I think red flags are, of course, clinical. Remember to feel pulses in both arms. Remember to feel pulses in lower limbs. And of course, bruit and other things will be something which a cardiologist will be more accomplished. But I think femoral pulses, any physician can feel femoral pulses. Raised acute phase reactants. Most important imaging is CT angio. In our setup, it is CT, but if you ask the rest of the world, MR is probably more approachable because it does not have radiation associated with. And of course, you can confirm it by using various criteria that we do in clinical practice. One of the important things is to see is the disease active or not? It's crucial for me because I'm an interventional cardiologist, and if I'm going to intervene on that patient, I need to make sure that there is no activity. And that's where I would involve the rheumatologist. I will request my rheumatologist to see if there is an activity, the child needs medical treatment, and once the activity has settled, only then I would consider doing an intervention, whether that's balloon dilatation, surgery, or stent implantation. And you can see there are various criteria. All of these are extrapolated from adults. There are not enough randomized controlled trials in pediatric population to actually validate these criteria which are being used for adult population. So how do we manage them? I think, of course, there are three contexts of management. The medical management, which will involve obviously immunomodulating drugs, treatment of hypertension, and prevention of thrombosis. We routinely use aspirin in these patients as an agent to prevent thrombosis. And of course, in certain selected cases, once the activity has settled, then you will either go for surgery or intervention. I think you are more qualified for medical treatment than what I would be telling you. But just to highlight, I think the first line treatment in all these patients is steroids. We use high dose prednisolone, 1 milligram per kilogram per day, maximum of 60 milligrams per day. You can use IV pulses as well for severe life-threatening Takayasu. And in pediatric patients, we use IV pulse plus low dose, which is often preferred. And once we have achieved the remission, then we start tapering them. And these are the guidelines which we follow at the moment. Of course, you can add on once you feel like, and the drugs which are being used in pediatric population are methotrexate, azathioprine, and of course, many other drugs. Cyclophosphamide is reserved for very severe cases. And I think since the biologics have come in, most of the people would use biologics rather than using cyclophosphamide. So that's not really something which is being preferred, but all the data on biologicals in pediatric age group is an extrapolation, because pediatric studies are so limited in terms of numbers that there are no randomized controlled trials on these drugs. Of course, interventions are either surgery or intervention. And that's again, if it's a coronary artery involvement, it becomes easier. CABG is obviously preferred because it has a lower restenosis rate in these patients as compared to angioplasty. Angioplasty in a patient with coronary artery disease and Takayasu is extremely difficult. You will need multiple stents and still you will not be able to achieve the good result. Of course, if it's aortic regurgitation, you need to replace the aortic valve. But if you find aneurysms and hypertension, long segment coarctation, the treatment is intervention and not surgery. Surgery in these patients can be extremely high risk. So that is where the role of an interventionist comes in. Of course, for pulmonary hypertension, you can treat the underlying disease and PAH. Percutaneous transluminal angioplasty is the palliative procedure which we perform, and I think the success rate is anywhere from 56 to 80%. This is the largest series from India. There is a recent paper also from the same group where they have used covered stents instead of normal stents. You need to do pre-intervention imaging to make sure that you get the exact segments and exact involvement of branch arteries as well. Once you have done that, then it's done under general anesthesia. You need a femoral access. You use heparin, complete hemodynamic and angiographic data, and then you use guide wire to cross and multi-track catheter for the procedure. You can see the procedure here. We are using a balloon here to dilate that very hard fibrotic vessel. You can see some degree of success. You can see the complete disappearance of waste. But once we did the angiogram again, you can see a very irregular pattern of that aorta. So same rules apply as for native coarctation. You try low pressure balloons first. If it works, great. Otherwise, you will do high pressure balloons and stenting. And these are the different covered stents we use in these patients, particularly the CP stent. Before I finish, I thought I will show you an adult case. This is a 38-year-old female, mother of 2 children, had severe headaches, but BP was checked in right arm always, and it was always low. Until her real nephew, who is a renowned pediatric cardiologist from US, came and actually examined her in full. Found that she had almost absent pulses in right arm and completely absent pulses in femoral arteries. And the cardiologist who was checking the blood pressure would always check it in the right arm. And because the right arm was involved, it would always come low. So nobody bothered to actually investigate her further or examine her further. And she had marked left ventricular hypertrophy, stenotic innominate, and CT confirmed classical Takayasu arteritis. And this is the angiogram that we did together. You can see very abnormal aorta. We went ahead and did a balloon dilatation first, didn't work. We did the measurements and went ahead and put a covered stent in that particular area. You can see a long covered stent being put in at the side. You can see the dilatation of covered stent, and the final result, you can still see some narrowing at the top because we were not able to dilate that fully. But her hypertension resolved, of course, on treatment, and she is extremely well. She can see a major change in her life since then. Remember the complications. Because these are very fibrotic, stenotic lesions, you can create dissection. You can produce aneurysms and aorta can rupture. And I've seen that in a live case of Takayasu arteritis in CSI Frankfurt, where it ruptured and they had to put in 2 covered stents in that particular patient. Of course, malposition, restenosis. Lastly, how do you monitor them? Of course, 4-limb blood pressure measurements. The prognosis, there is a relatively high mortality. Cardiovascular disease is the #1 cause of death, and the modifiable mortality risk factor is hypertension. Of course, if the coronaries are involved, that actually affects the long-term prognosis significantly. And there is a very high relapse rate. So you need to be very careful, and it is really a combined management by both rheumatologist and pediatric cardiologist. To sum it up, I think Takayasu arteritis in children is more dangerous. It's 2 times higher mortality than adults, and that is driven by cardiovascular complications. We see Takayasu first because it is usually unexplained hypertension, aortic regurgitation, or heart failure. And 30% of these patients have coronary artery disease, which is often silent, and routine coronary screening is essential. Of course, diagnostic delay is harmful. Each month of uncontrolled inflammation would lead to premature or permanent vascular damage. And I think use of biologicals have changed the outlook of these patients, because if you can use them and reverse the process or at least manage them, and then once they are in remission, then the cardiologist can come in and go ahead with either surgery or intervention. But it must be in its remission phase. And that's why close collaboration between cardiology, rheumatology, and surgery is crucial. Of course, interventional treatment is effective palliation in short and medium term, and a combined surgical interventional treatment may be necessary. It's a lifelong disease, remember. It is a lifelong disease. You keep on having remissions and relapses. So I think serial multiple interventions and a medical supervision by a rheumatologist. Every child with unexplained hypertension, absent pulses, or heart failure deserves a vascular diagnosis. Thank you very much. I will be happy to answer any questions if there are any. Sure. We monitor them with serial CT. Ideally, they should be monitored with MRI. But because availability of MRI is an issue, and in pediatric age groups, sometimes even doing an MRI is an issue. So we monitor them with serial echocardiography and CT. Of course, you go on and do acute phase reactants, their ESR, CRP, and a very close collaboration with rheumatologists.
Sir, one question. When you measure the blood pressure, it is always different in different limbs. So what is the accurate measurement of the blood pressure? What do you recommend? It should be intra-arterial or something else while you are giving the antihypertensive especially, whether these antihypertensives are working or not. So what should be the accurate measurement of the blood pressure while dealing with Takayasu arteritis?
Very good question, because that's really the tough part. Most of the times what happens is that usually one of the limbs would have hypertension out of the 4 limbs, and that usually becomes your reference points. But in a very rare case where there is none of the limbs actually has a high blood pressure, then once you have done an invasive monitoring, you would know the difference between the actual and what you are measuring, and you need to keep a record of that. That's the only way. Otherwise, each time you cannot do an invasive monitoring.
Sir, a similar question, sir. What if if it is not a pulseless disease? The pulses are present and palpable, and still you are suspecting Takayasu. How do you suspect that?
Sorry, I didn't get the question properly.
The pulses are present, the peripheral pulses are present, but we don't know. But as a cardiologist, your suspicion is that it is Takayasu disease. So what should a rheumatologist proceed as?
I think if all the pulses are palpable, what actually that tells you that your major head and neck vessels and your descending aorta is not involved. And that's how, but your renal arteries could be involved, your coronaries could be involved, your pulmonary arteries could be involved. So a CT angio would still be required to make sure, because unless you have an evidence of arteritis and involvement of an artery, you cannot make a diagnosis of Takayasu arteritis.
Thank you so much.
Takayasu arteritis, that is going to lead to absence of the pulse, right? My question is, while I'm working in a 14-year course in a platform, she has chest pain. I have two things in my mind. Takayasu arteritis, and the second sort of thing is Kawasaki disease. This is my difference, right? For the chest pain in a young, how I proceed? Is CT angiography or should I start with some medication? What is my approach towards a young patient presenting with chest pain and I have two differential diagnoses, Takayasu arteritis and
Kawasaki. Thank you very much. That's a very good question. For me, it's relatively simple because what I will do is after getting an ECG, I will do an echocardiogram. I make diagnosis of Kawasaki disease on echo because to make a diagnosis of Kawasaki disease, you need to have coronary artery dilatation. And coronary artery dilatation is classically seen with Kawasaki disease. You will have aneurysm formation, and the only thing which will be involved will be coronaries. In Takayasu arteritis, of course, 30% of the patients may have coronary artery involvement as well, but that's stenotic lesion and usually not an aneurysm. And they will also have involvement of aortic arch in addition to the coronary artery involvement. So diagnosis of Kawasaki disease is fairly simple because there is only involvement of coronaries and no involvement of major vessels. In Takayasu arteritis, you have involvement of major vessels. I will do an echo first as a cardiologist, and most of the times I will be able to differentiate whether it's Kawasaki disease or Takayasu arteritis.
adult patients that Takayasu arteritis is our diagnosis. Temporal artery biopsy is the first line, or temporal artery pulsation is there, or they are coming, they get blind with that Takayasu arteritis. Should we start practicing those or should we wait on the biopsy? Is temporal artery biopsy, my question, is the diagnostic test for Takayasu arteritis in adults?
I would let an adult rheumatologist answer that, but if you ask me, involvement, obviously temporal artery involvement is one of the major clues towards the diagnosis of Takayasu arteritis. So if the CRP is raised, if ESR is raised and there is evidence of activity, you should start steroids before waiting for biopsy. Thank you very much. Thank you.
I have a question. So in a patient with Takayasu arteritis with renal artery involvement who presents to us with raised blood pressure and has fibrotic renal artery, the disease is controlled, ESR CRP is now normal and there are no constitutional symptoms. How can we help the patient in case of renal artery involvement?
You will have two types of patients who would have renal artery involvement. One, those who would also have abdominal aortic involvement as well as renal artery involvement. And second, very rarely you would have only renal artery involvement. If it's only renal artery involvement, we will go ahead and stent that. If it's an adult patient, we go ahead and stent those patients.
In a fibrotic vessel,
oh yes,
you
can stent. You will have to use a covered stent because it's a fibrotic lesion. So for a fibrotic lesion, ordinary stent may cause dissection. But if you use a covered stent, you can actually dilate those vessels very nicely. If it's a arch involvement as well, then you always treat the proximal lesion first. So we will treat the arch first, the descending aorta, stent that first, and then go into both renal arteries and stent them as well.
And cardiologists are performing this renal artery
Yes.
stenting, and which centers in Lahore?
We do not, unfortunately, have many interventional radiologists in the city. So that's why we are doing it. Ideally, renal artery stenosis stenting should be done by an interventional radiologist.
Thank you, sir.
Thank you.
Thank you, Dr. Masood, for this highly enriching talk on Takayasu's arthritis. Now I would call upon the stage Professor Dr. Tafazul-e-Haq Mahmood for souvenir presentation to Dr. Masood Sadiq.